presented by a brilliant clinician and a medical politician, brilliant medical politician. So it's really good. So now comes the main act, and it's Professor David Bennett, who's all of these things. So that's fantastic, because David is not only a clinician, but a scientist. And he's professor of neurology. About a third of his work is clinical, and about 2/3 is science. And he told me before that he's actually having to work to look after the wards and the services when the doctors are on strike, the junior doctors are on strike. So he still has a very important clinical role to play, but his interest, his research interest, is in peripheral neuropathy and neuropathic pain. And of course, the point about the lectures that we give, it's on something which is cutting edge and new. And David is really, really interested in personalized pain management, and particularly in neuropathic pain. So David is going to give our plenary tonight, and he's going to talk about using a stratified medical approach, medicine approach, to improve understanding, diagnosis, and treatment of neuropathic pain. As well as all these things he does, he's a keen mountaineer, and maybe you can say something about that. Do you drink wine at mountains? Are you going to slow?
I know generally doesn't mix very well.
David, welcome. Thank you very much for joining us.
Thanks very much. So we're just going to do a switch on computers. Yeah. Back in Liverpool, I was reflecting that the last time I was here was over 20 years ago, when I was doing my clinical exam for MRCP. So, which I did pass, and but it's nice to be here in more relaxed surroundings. Yeah, I'm not sure what the patients thought of me being a junior doctor back on the ward, but so it'd be interesting to have their view on that. But thank you very much for asking me to give this lecture. It was lovely to hear about William Campbell. He's not someone that I knew of, but didn't know personally. And of course, Steve McMahon was really a long-standing mentor to me, so it's an honour to give this lecture. So I'm going to talk on the topic of neuropathic pain, which is really my kind of both my clinical and my research interest. And what do I mean by neuropathic pain? Well, we have this complex somatosensory nervous system that we're showing this in simplified cartoon here. And whether it's damage to the terminals of sensory fibers in the skin, whether it's damage to a nerve trunk, for instance, in peripheral neuropathy, whether it's a radicular problem due to disc disease in the back, or something more proximal within the spinal cord, injury to that somatosensory pathway can give rise to neuropathic pain. And that's really the topic of this talk today. It's not uncommon. So, you know, the kind of early surveys using questionnaires to try and work out, you know, what proportion of the population have neuropathic pain. Most of them come in with a prevalence of about 7 to 8% of the general population. So this really is a common disorder. And to kind of bring that up to date, so I was part of the team that enhanced some of the pain questionnaires within UK Biobank, which is a big biobank within the UK. We had about just under 200,000 people fill in questionnaires, that including the DN4 questionnaire, which is a pretty good screening tool for neuropathic pain. And we got a very similar figure. So in UK Biobank in the UK, which is probably the biggest population survey that we have, it was around about, again, 8% of people were suffering from neuropathic pain. And we could see some of the kind of typical epidemiological factors that we would expect. So more common in women than men, more common in people of lower socioeconomic status, and we could really see very severe negative impact on quality of life. And certainly comparing, maybe it's not helpful to draw comparisons, but if you were to compare neuropathic pain to non-neuropathic pain, it was really, the neuropathic pain really stood out as having a really negative impact on quality of life. So there's clearly a lot we need to do in this area to try and improve understanding and management of neuropathic pain. So kind of that's my selling point as to why this is an important problem. I suggest that probably many of you don't need convincing. What do I mean about kind of taking a multimodal approach and stratifying our approach to neuropathic pain? Well, what I'm saying is, in a general population, you'll have some people that have neuropathic pain, luckily many that don't, But even with those within neuropathic pain, they're actually quite a heterogeneous population. And by understanding that variance better, hopefully we can both understand the problem and also target our treatments. So the kind of workflow I'm going to talk through today is kind of what modern approaches can we bring to bear on this problem? Well, it's better clinical understanding, and there are some kind of very simple clinical processes that we can go through. It's a better understanding of sensory profile, so that might be both the sensory symptoms people are experiencing, but also testing the system with quantitative sensory testing. It's some of the new molecular tools that we have, and I will be going through some of those today. Genetics is a particular interest of mine. It's physiological tools, whether that's brain imaging or electrophysiology. And finally, not to forget, but those psychological comorbidities such as anxiety, depression. So psychology is incredibly important in the experience of pain. And we need to draw those together. It's kind of interesting how rapidly things like machine learning and computational techniques are expanding. And I will talk a little bit about that later. And then hopefully we can start to stratify patient groups. That's going to help us in our understanding of underlying pathophysiological mechanisms and hopefully more accurate diagnosis. And of course, what we finally want to achieve is a better management of neuropathic pain. So just to start kind of on the kind of more clinical and sensory profiling end of the spectrum, and I'm going to talk about an example of how we can use this kind of approach to better understand disorders, which in some ways the underlying kind of problem was not well understood in terms of neuropathic pain. So the example I'm going to give is non-freezing cold injury, which used to be called trench foot, but the modern name is non-freezing cold injury. And it's still true to say that this is a disorder that's very much focused on the armed forces. And these are men of the Yorkshire Regiment in the First World War, typical conditions, cold, very wet, and there would be a group of soldiers that exposed to these really tough environmental conditions would develop painful, usually feet, often with some swelling and sometimes with some vascular change. And if they weren't taken out of those conditions, that could turn into a really nasty, persistent chronic pain problem. Those injuries still happen today, unfortunately. They weren't well understood, and the Ministry of Defence said, well, we don't really understand to what extent this is vascular, to what extent there may be neurological involvement. Is this a neuropathic pain condition? And so they asked us to look into this, which we did in a cohort of soldiers that had kind of long-standing and disabling non-freezing cold injury. And you can see in this picture here, the distribution of the pain is very much in both length dependent and probably also those areas that were exposed to those conditions, so the hands and the feet. And when they were filling in one of those screening questionnaires, which is looking at the quality of the pain that they're experiencing, the DN4 questionnaire had many of the features that we would expect in neuropathic pain, with the burning pain, electric shock sensations, and they all scored highly on that questionnaire. We could then look at sensory function in a bit more detail with quantitative sensory testing. So this is the idea that you're giving a defined sensory stimulus, you're asking people what they perceive, and you can test different sensory modalities, whether it's a change in temperature, whether it's a mechanical probe. It's a technique I've always quite liked because I think it gives insight into the sensory nervous system. A bit like the electrophysiology that Tony Dickinson was talking about, you can kind of see, as it were, physiology in action. And it was a technique actually that Steve McMahon and I would quite often do together, initially on healthy subjects, and then as I transitioned to a clinician, in patient cohorts. And this technique has improved as it's become standardized. And if you were to look across a range of sensory modalities in these cohort of soldiers or veterans with non-freezing cold injury across different sensory modalities, you can start to see how they perform relative to control. So upward would be a gain of function, down would be an impairment in function. And they've got some impairments, for instance, in mechanical detection. And one thing that was quite interesting is when it came to cold pain threshold, they were actually hypersensitive. And the reason that was interesting is that actually many of these soldiers find that their symptoms, they get a recurrence and they worsen in a cold environment. If you examine these participants, then they have a loss of sensory function in a kind of length-dependent distribution that we'd expect in the sensory neuropathy. And when you do a skin biopsy and you count the number of small nerve fibers, as we can do in the skin, because we can stain for the nerve fibers shown by those red arrows on the top in a control. You can see in those people with non-freezing cold injury, they've got a real loss of those small nerve fibers. And this really helps us understand this disorder, that in fact it's a painful sensory neuropathy. That's the bottom line of what's causing this persistent problem in the chronic non-freezing cold injury. And actually, really what I've just done is I've just walked you through the kind of the neuropathic pain special interest group grading system of neuropathic pain, which I think is quite a useful, it's published in 2016. I think it's quite a useful kind of clinical workflow. It's quite intuitive because it starts off, do we think people have symptoms in the distribution we'd expect that makes anatomical sense? Do they have sensory signs on examination? And then when you do more specialized tests, such as the quantitative sensory testing and the skin biopsy, do you have evidence of a damage and an injury to the sensory nervous system? Why is this pragmatically important? Well, I can tell you, it's been very helpful because actually you can get these people that suffer this condition into the right clinical management pathway. We had lots of discussions with the Ministry of Defence. They've changed their whole medical pathway also in terms of trying to prevent these injuries within soldiers. And we formed a kind of steering group for non-freezing cold injury across the UK. And the latest data is that the number of injuries are reduced by at least 50% over the last 5 years, actually. So that is a positive. When you can understand the problem, you can start to get people into the right management pathways. So just to kind of move on to, so non-freezing cold injury still happens. It's relatively rare, thankfully, because it really depends on a certain environmental exposure. What about a very common disorder, and that's painful diabetic neuropathy? And that's going to become more common, unfortunately, as we have an epidemic of diabetes in the UK as there is around the rest of the world. And I think this, in terms of deep phenotyping and trying to understand the problem of neuropathic pain, there's some very interesting and simple comparisons that can be done. It's very interesting that some people develop diabetic neuropathy and it remains painless for the rest of their life. Some people develop really disabling pain as a consequence of diabetic neuropathy. What is it that seems to cause that transition? And that's been a theme of my research really for the last decade, and will be something of a theme of this talk. So over 10 years ago, I started to study with Andrew Rice and Solomon Tesfaye, which was partly just to look at that dichotomy, compare patients with diabetic neuropathy without neuropathic pain and those with. And you can see again, those patients with the neuropathic pain, they've got this typical length-dependent distribution in red of the pain that they are suffering. One of the complexities when you start doing this kind of clinical research is those patients that don't have neuropathic pain, they still have pain, it's just of other origins. So they have back pain and hip pain, and trying to disambiguate those on clinical studies can be quite tricky. Again, following the theme I've said before, they have really, it has a big impact on their quality of life living with neuropathic pain. And just by some kind of simple clinical measures, you can start seeing some correlations and risk factors for neuropathic pain in diabetic neuropathy. So just to give you some examples, and it may intuitively make sense. So the TCSS is a clinical score of the severity of neuropathy. And you can look at the relationship between the kind of severity of neuropathic pain versus the severity of their neuropathy. And you can see overall, if you have a more severe neuropathy, you're more likely to have more severe neuropathic pain. The other relationship that we found and others have also found is the worse someone's glycemic control is, so the metabolic environment, the more likely they are to have severe neuropathic pain. So there potentially are some simple things that we could do, improving glycemic control potentially, and try and prevent neuropathy progression would reduce severity of neuropathic pain. We could also look more carefully at sensory profile. And sorry, this is a bit of a complicated slide, and I'll simplify it for you, which is to say that if you have diabetic neuropathy, in most sensory domains, whether they're mechanical or thermal, people will have a loss of function. And alongside the fact that I've told you that patients with neuropathic pain tend to have a more severe neuropathy, those patients with neuropathic pain tend to have a greater loss of function across a range of sensory modalities. And basically that's why you're seeing most of these dropping below the central line, because it's a loss of function relative to control. But I've kind of showed you a simplified picture where on the x-axis is the different sensory modalities, on the y you're looking at sensitivity compared to controls. that doesn't take away, that kind of takes away from the fact you can do a more nuanced analysis of sensory profiles, which is something that I would say that Ralph Baron, we've collaborated with him, but certainly the German Neuropathic Pain Consortium has really been leading on. And I think, you know, the principles of this are quite interesting. And that's to say that you could kind of group sensory modalities into thermal on the left here and mechanical on the right, and you can look at individual sensitivity and you can build up a profile. So as I've told you, most patients with diabetic neuropathy will have loss of function. So he's done a cluster analysis, and he's showing that he would call this the sensory loss group across a whole range of sensory modalities. But you can find people that are hypersensitive to mechanical stimuli. So he's termed that mechanical hyperalgesia. And you can find people that are particularly sensitive to thermal stimuli. And somewhat conveniently, if you do a kind of unbiased cluster analysis, you will find that most people can be grouped into one of these three groups. And the reason that I'm saying that is, if you look at across a whole range of different neuropathic pain disorders, you will find that actually, although the etiology might be quite different, you can identify these three principal clusters, although the frequency will somewhat vary. And I think the point Ralph has been trying to make, and I think it's relevant, is the fact that we shouldn't just be thinking about neuropathic pain in terms of the original etiology, whether it's, for instance, post-herpetic neuralgia, or whether it's painful diabetic neuropathy. Probably these clusters might be telling us something about underlying mechanisms. I think one of the challenges for the field is we don't yet have a simple relationship between sensory profile and underlying mechanism, but many of us are trying to build that up. And these mechanisms are likely to cut across different etiology of neuropathic pain. And I'm going to come on to it later, because actually that idea of subgrouping people in terms of sensory profile may be relevant to treatment choice as well. So moving on from, I've started off with some clinical techniques and sensory profiling, and now moving on to, I guess, Chris was talking about the new and the innovative. Well, molecular profiling is certainly something that we're seeing across the whole of biology and clinical medicine at the time. And just to kind of give you some idea about this, so actually a number of people in the room, such as Andrew, were involved in the study, which was the Bridge NIHR study, which was really a forerunner of the 100,000 Genomes Project within the National Health Service. And it's pretty amazing to think that kind of we've moved in my career from kind of occasionally being able to sequence one gene to now actually taking an individual and sequencing their whole genome and doing that in hundreds of thousands of people across the NHS. And I would say there are many things I would criticize in the NHS, but actually the fact that at times it can do a real proper national approach and really embrace some new technology, is it can do some things well. And this is an example of where it did do something well. And we were involved in taking people that had extreme neuropathic pain disorders and seeing how well this whole genome sequencing technology performed and whether it could provide us insight into genetic risk factors for neuropathic pain. I have to say this was really taking extremes, so either people with insensitive to pain or really quite severe neuropathic pain disorders. So we had recruited participants from around the UK, a number of different centres with these extremes, and undertook whole genome sequencing. And I think the interesting thing is, one thing I've learned when you kind of employ these new technologies, it's not that we have a lack of finding novel genetic variants. The problem is we almost find too many variants, and it's trying to interpret them and trying to decide, are they pathogenic? But we had a multidisciplinary team of geneticists, of clinicians, and actually we could make some of those decisions. And we found in a significant proportion of these patients, variants that we thought were pathogenic and were contributing to their condition. And if I had to give you kind of one take-home message from what was a complicated study, is that we were particularly finding variants in voltage-gated sodium channels. Now, maybe that's not a surprise. So voltage-gated sodium channels are very important in determining that neuronal function that Tony was showing you and talking about, Steve McMahon's interest, is a key determinant of excitability within neurons. And some of these voltage-gated sodium channels where we were finding variants are highly expressed within sensory neurons. So just to give you one example of one of those channels that was highlighted as part of that study, that's a voltage-gated sodium channel called NAV 1.7. And I think it's interesting because there's some very extreme and rare phenotypes that are strongly linked with variants in this channel. So I've shown you one here. that's inherited erythromelalgia. And this is one of my patients actually with, you can see her red feet, and she'll get pain attacks exacerbated by warmth. It's incredibly disabling and it's difficult to treat. And we now know that there's more than 20 mutations in NAV 1.7 linked to this disorder. And essentially what those mutations are doing is they're making this ion channel more likely to activate. So they gain of function, and that's enhancing excitability. Interestingly, there's another disorder which actually has some features, but also quite distinct, called, it used to be called familial rectal pain, now called paroxysmal extreme pain disorder. And again, it's severe pain, but now with erythema in the perineal region, can be very different, can be also associated with erythema and pain around the mouth. And that's also due to gain of function mutations in NAV 1.7. And these mutations are stopping the channel from inactivating. So when it switches on, it stays on for a long period of time. And then there's another disorder. In the top two clinical phenotypes, the small fibers, the C fibers, nociceptors, are structurally intact. They're just hyperfunctional, hyperexcitable. In the bottom disorder, you actually get degeneration of the terminals of those nociceptors called a small fiber neuropathy. And there is a subgroup of patients with small fiber neuropathy that also have variants in this same ion channel. So we can see we've got one ion channel where you have particular clusters of variants causing quite specific clinical phenotypes. Now, these have the commonality that what seems to be the end result, and this is work from Suleiman Dibhaj, of hyperexcitability and increased action potential generation. We went on to look at a more common disorder now. So we've been discussing painful diabetic neuropathy, and I guess we asked retrospectively what was quite a simplistic question, but it seemed to work out. And that was to say that if we look for variants in the same ion channel, NAV 1.7, do they segregate between those patients with the painless versus those with the painful diabetic neuropathy? And actually the answer to that was yes. So we found in around 10% of patients with the painful diabetic neuropathy, we were finding rare variants in NAV 1.7. And so we're kind of moving from kind of Mendelian, very rare disorders to now quite a common disorder. And these variants are probably acting more as risk factors. So just to highlight the fact that these people, they weren't born in pain, they lived a normal life until they seem to have this interaction between a genetic risk factor, this rare variant in NAV 1.7, and a metabolic disorder, the diabetic neuropathy. And I think one point just to make is it's really incredible now we're beginning to understand the structure of ion channels. So these are key determinants of excitability. They're mediating the ionic flux across membranes. And now we can map these genetic variants to the exact amino acids where they are in the ion channel, and we can start making predictions. For instance, this M1852T is in a region that we think is probably like very important for inactivation of that ion channel. So we can build these three-dimensional models, and then we can get a genetic result, and we can start making some predictions about what that genetic variant is doing at a physiological level. And then we can go on and we can test that prediction. So for instance, we can undertake patch clamp analysis. We can express that mutant ion channel and say, what does it actually do to the function of that channel? And so we've taken here two of those rare variants that we found with the painful diabetic neuropathy group. And to cut a long story short, essentially what we're finding is they're altering the inactivation properties of the channel. And so what's happening is an increased drive. So the window current, which is can be thought as the driver of excitability as a consequence of that mutation, is going to enhance excitability of nociceptors and is likely to lead to ongoing primary afferent activity that's driving that pain state in diabetes. Just to say, you can kind of try and draw those two themes together, and I think probably we need to do that more in the field of neuropathic pain and say, okay, so if you have patients with rare variants in NAD 1.7, is there anything that you can say about their sensory phenotype that seems to be kind of identify them as having those rare variants? And actually, we did go back and look at that retrospectively. It was quite interesting. So they have higher scores for burning pain if they have those rare variants. And when we do the quantitative sensory testing, we find that actually on the extreme right here is pressure pain. They seem to be more sensitive to pressure pain. So there may be some clues in the sensory phenotype. It's not going to be an absolute. It's going to be a kind of relative issue, but there seem to be some clues that they might be harboring a rare variant in NAV 1.7. So we've kind of, that's just to give you an example for some molecular profiling. What about Steve McMahon's lab, which was physiology? Well, we'll give you an example actually that arose from our work within the pain consortium that Tony Dickinson was telling you about. And although I kind of work on neuropathy, and I would say probably my first love is the primary afferent nociceptor, that first step in the pain pathway, I do have to concede that ultimately we perceive pain in the brain. I can't get away from that fact. And the brain, however, is not just passively receiving information. So actually much of Tony's work in his career was to say that the brain is sculpting the way that information arises up to it from the spinal cord. There's in fact a descending pain modulatory system, starting in areas such as the anterior cingulate cortex, pathway down to the periaqueductal gray, and then down to the spinal cord. And that has a really powerful influence on the way pain signals are processed within the dorsal horn of the spinal cord. And I think a nice analogy here is good cop, bad cop. And that's because depending on circumstance, for instance, whether you're anxious, whether you're depressed, whether you're paying attention, that can really influence that signal. So the good cop will use neurotransmitters such as opioids and noradrenaline that can switch off processing at the dorsal horn of the spinal cord, whilst the bad cop actually can facilitate processing. And the reason I particularly like this analogy is it depends on if you have children, how old they are. But if you saw the Lego movie, you will know that the good cop and the bad cop in that film, they're the one and the same person, the head's just swiveling around. And of course, all of us are, depending on our circumstance and what's happening that day, may be in a state of actually descending pain modulation, shutting down, or actually enhancing pain signaling at the level of the spinal cord. So I think it is a nice analogy. And just to highlight that the periaqueductal gray is a real hub of that control. It's actually when I moved to Oxford, I was lucky enough to be based and have a colleague in Irene Tracy, who's now the Vice Chancellor of Oxford, and she had a very strong interest in functional brain imaging. And so we did exactly the same principle, which is we took patients with painful versus painless diabetic neuropathy, and we said, what can we see in terms of the kind of activity in terms of absolute blood flow and response, both in the resting state and the response to noxious stimuli in these two different groups of patients? Can we tease out some of these differences? And in fact, we could. And that region I was telling you about, the periaqueductal gray, which is a really important hub for that descending pain modulation, there seemed to be a difference in the way that was connecting to the descending system from the prefrontal cortex. And we actually found in those patients that had neuropathic pain that there was facilitation going on, and that facilitation was enhancing signaling and really maintaining that pain state. So it was a kind of nice idea of kind of drawing some preclinical data that Tony and others had developed and actually getting some physiology in humans to suggest that there's a descending pain facilitatory state within a subgroup of these patients. And as I've said, I guess carrying on the theme of the brain, although I love molecular profiling in terms of predictive effects on whether someone is likely to develop a chronic pain state or not, I suspect that psychological comorbidities are going to be much more powerful. And part of the reason that I say that, so like Mac, I'm a great lover of international and national collaboration. And I led a group called Dolorisk, which was a European study with lots of different centers. And the advantage of that is in a harmonized way, we could generate and create data from lots of patients across Europe. And we could collect both clinical data, biochemical variables, and we did that in kind of, as it were, a test group. And then and we said, what factors can help us predict who is going to be in a chronic pain, neuropathic pain state, and we could then kind of test that prediction in a validation cohort. So we did that within this consortium, and we applied that kind of, I was talking about computation, so that idea of prediction, machine learning, as many of you will know, is a kind of powerful computational tool to do that. And we could find actually the predictions from a machine learning program using a huge number of these variables were quite powerful. And what was interesting was that some of the factors that I've already told you we saw in the smaller cohorts did come through when we did this machine learning event, and that was the higher poorer glycemic controls at the higher HbA1c, a higher BMI, but the factors that came out loud and clear were psychological factors such as anxiety and depression. I think they're incredibly important, and we're kind of extending this now, and we're following patients more over time. And again, the baseline scores for anxiety and depression seem to be very predictive of incident neuropathic pain, which I think is very important. And I think, don't forget, that is something as doctors we could potentially intervene on. I think, unfortunately, psychological therapies are under-resourced within the NHS, but I suspect they're going to be very important. So hopefully you're going to be able to integrate this information, and then that's going to allow you to subdivide patients into groups and better target your treatment. So I think just for the last 10 minutes or so, we're just going to talk about kind of how we might improve the precision of our treatment and how we can integrate some of that information. And like kind of on this slide, you're kind of going from empirical state, which is where we mainly are at the moment, and with the idea of can we stratify or can we even personalize. I'll give you some examples of each. So I think where we're at the moment is often we are using an evidence base in kind of for treatment in pain. Often that's in the form of meta-analyses of clinical trials, but those clinical trials are often relatively unselected groups of patients. They're not clinical trials where we're stratifying patients. And I think probably in terms of, where would you go to in the current state of the art, I think that the meta-analysis of and systematic review of pharmacotherapy for neuropathic pain, which was produced by Neupzig and published in Lancet Neurology back in 2015, is still very good, actually. And I know that Neupzig are just in the process of beginning to revise all of this again, and probably also including some non-pharmacotherapy as well, which is a great idea. And the idea here is you will look at a number of trials, you have a metric of the quality of those trials, and then you will kind of concatenate that information to get an overall effect of a pharmacological agent in the treatment of neuropathic pain. And what you'll find, I'm not going to go into all the details, but is the clinicians amongst you, the medications that you're probably most familiar with and which are actually kind of recommended within the NICE at the moment are very much the first-line treatments for neuropathic pain in that systematic review. And I should say that there is some evidence sometimes that we should combine therapy. So we were discussing earlier, what was a number of us were involved with a very complex trial called Option, which was to take patients really over the full course of a year and try lots of different pathways for pharmacotherapy of painful diabetic neuropathy. And this was a trial that was run by Solomon Tesfaye, which, I mean, Solomon should get a prize because it was a Herculean effort to get this trial working. But the point I'm trying to make is that actually it was looking at combinations of pregabalin, amitriptyline, duloxetine in various combinations in these different pathways. And the bottom line is whether you're kind of starting pregabalin and adding amitriptyline in, or starting with duloxetine and adding pregabalin in, it didn't seem to make much difference. But there was some evidence in the kind of gray is the monotherapy. So it started off with monotherapy and then an add-in of an agent for those that hadn't responded adequately to the monotherapy. There was some evidence of some, it's not a huge added benefit, but there was some significant added benefit of the combined treatment. So combined treatment does seem to have some benefit, but actually, despite the fact we were hoping to find, as it were, the perfect pathway, we actually found that the various pathways overall statistically had very similar efficacy. I think also the salutary lesson from this is you can see how terrible our current treatment for so painful diabetic neuropathy is, okay? So, although there is some improvement and it's statistically significant, unfortunately, many patients are still living with disabling pain, despite kind of going through this year trial of lots of different pathways. So I guess the idea would be that maybe if we could stratify patients, that could help us improve that current situation. And I think we're moving in that direction. I mean, I have to say it is a challenge instituting some of these kind of tools I've told you about. I think there are some examples. So I think probably one of the better examples in terms of sensory profiling is this study from Soren Sindrup and Troels Jensen, where they used sensory profiling in a manner I was telling you about. So they used quantitative sensory, so they took a cohort of patients that were mixed. They used sensory profiling, and essentially they split the groups up into, there was a group that they've called the irritable nociceptor. Essentially, that's those with the gain of function that I was showing you earlier in that clustering analysis that Ralph Baron had done. So they're hypersensitive, particularly to mechanical stimuli. And they had another group which they called the non-irritable. Many of those basically have loss of function, which is kind of simplified in this simplified cartoon. And they did this a priori at the beginning of the trial. And they made a prediction, which would say that we think those that we've called the irritable nociceptor group, on the basis of this sensory profile, that what's going to be happening is they've got ongoing activity in their nociceptive afferents, and they're likely to be particularly sensitive to a drug that blocks sodium channels, and they used oxcarbazepine, and actually that the data did move in that direction. So when they looked at the number needed to treat, the number of people you need to give the drug to see a significant benefit, it was much lower in the oxcarbazepine group in the irritable nociceptors than it was in the non-irritable nociceptors. So I think that does provide some pretty good evidence that actually here, by stratifying patients, is being predictive of treatment response. I think, you know, companies are interested in this, and the problem is that it's not easy running a clinical trial with quantitative sensory testing at the front end of it. But I definitely think we need to be thinking, how can we tease out patients and trying to work out who are most likely to respond to a drug? Because we might be losing lots of signals in clinical trials because we're just, as it were, putting all patients together rather than teasing out specific mechanisms. There are not many examples I can give you of truly personalized medicine. I'm going to give you a couple. And being interested in genetics, I'm afraid I'm a bit biased on this, but I think they're very nice case of points. And as it were, if you think about it, the cancer field is way into truly personalized medicine in terms of genotype. And we've got a bit of catching up to do in the pain field. But I'll give you one example. So we spoke earlier about this disorder, inherited erythromelalgia. It's the disorder with the painful red feet, where warmth makes the pain worse. We have this bunch of mutations in NAV1.7 that can cause inherited erythromelalgia. If any of you have looked after these patients, that it's really tricky to treat. And actually, mostly they don't respond very well to kind of our non-selective sodium channel blockers. But there was one family in the States that Steve Waxman and Suleiman Dibhaj were looking after, where they seemed to respond particularly well to carbamazepine, which is the exception rather than the rule. But the reason I like this study published by Steve and Suleiman was that they used the idea of three-dimensional modeling of the channel that I showed you earlier. And they knew that the people with this particular mutation, V400M, had responded to carbamazepine. And they saw that there was an amino acid that was very close in not in linear space, but in three-dimensional space, that was very close. And they said, well, our prediction would be, given that those residues are energetically linked, that will also respond to carbamazepine. And so they went on and they did, first of all, they did electrophysiology in a dish, and they showed that indeed this mutation does respond to carbamazepine. And then actually, credit to them, they went and did a very small, because there weren't many people with this disorder, but they did a randomized blind trial, and they showed that actually clinically, they responded to carbamazepine as well. And this is, as it were, jumping within one ion channel. And it so happened that at the same time as they just published this, we found in a related sodium channel, NAV1.8, as it were, the exact equivalent amino acid position, another mutation. And so, you know, first we've jumped within one ion channel, and now we're jumping to a completely different ion channel, but the equivalent position. And we could find, again, if we do this kind of structurally modeling, we can literally overlay where this position is. And we found that this was also sensitive to carbamazepine. And then just finally, I suppose the dream scenario is to say that could we, can bring this data together, can we actually treat the underlying cause of neuropathic pain? And I can give you one example where we're moving in that direction. So just going back, in that genetic study bridge I was telling you about, most of the variants that we found were in sodium channels. But we did find one disorder called hereditary sensory neuropathy type 1, which is a very painful neuropathy. There's a founder effect. It has a genetic cause. It's due to a mutation in a gene called SPTLC1. And it's particularly common, actually. Although it's a rare disorder, it's relatively common in the UK because there is this founder effect. And it's interesting, and I won't go into all the details, but basically it's a toxic neuropathy due to a biochemical change. And what's happening is the mutation, this enzyme normally adds serine to palmitoyl-CoA to make a component of membrane sphingolipids. But with this mutation, it adds alanine or glycine to palmitoyl-CoA, and it makes a toxic metabolite that the body can't clear. And we could actually model that because now we can use induced pluripotent stem cells to generate sensory neurons, as it were, in a dish, which I think is very powerful. We're now moving to actually, we can take human genetics and we can now make a neuron where we can try and understand the disease process within a dish. And when we do that, and we make human sensory neurons in a dish, and we measure the amount of these toxic metabolites, they're massively increased within the patients, really confirming that we think that is what the pathophysiological basis of this is. But it does get one, we can make another increment on that. And that's to say that if you kind of understand the biochemistry, you would say, well, maybe if we add lots of serine, we can compete out the substrates we don't want this enzyme to work on. And so if we do that, we're going to reduce the amount of those toxic metabolites just by adding serine to those cells. And in fact, that's exactly what we saw in terms of a key outcome. So this is now staining those neurons and looking at axon outgrowth. So these are the, as it were, key signaling arbors of these sensory neurons. You can see the massive impairment you get in hereditary sensory neuropathy as a consequence of the mutation. We now add serine to these cultures and we can get this almost back to normal. So now we've kind of gone from human genetics, understanding pathophysiology, to potentially testing a treatment in a dish. And I'm pleased to say that now we've, as a consequence of that, and kind of working with Mary Riley, who was a kind of key collaborator on this project, Mary has gone to the CMT Association and got funding for a trial. So we will now be giving, we can identify most of these patients across the UK, and we're going to be giving them a trial of serine. And of course, our hope is that it's going to restore function in the context of this painful sensory neuropathy. So I think that's a kind of nice example, as it were, of trying to close the circle of going from understanding mechanism to actually treating the underlying disorder. So really, just to conclude, I think stratification is really helpful. It's really helpful in us understanding the basic pathophysiology of neuropathic pain. I think we need to be building stratification and embedding it. And I've taken this slide actually from a review that I recently wrote with Tony Dickinson and Ralph Burron, really throughout the drug development process. So even preclinically, we need to be trying to map some of those mechanisms better to understand how they might relate to clinical pain states. I think some of these cellular models are a great bridge if you're moving, again, from basic pathophysiology to potentially bridging to phase 2 studies. And even in some of these very large clinical studies, I still think some of these simple, for instance, questionnaires trying to tease out qualities of pain sensation can be very helpful in stratifying patients. And I think we just need to be doing it through the whole drug development process to prevent us to understand disease and also really get the optimum treatments to the right patients. So I'm just going to end there. This is my very simple conclusion, which would be that we need an interdisciplinary approach. I think we need to understand the multiple mechanisms that underlie neuropathic pain. I don't think there's going to be one, and I think it's going to be quite challenging in patients to work out how, for instance, these different factors interact. But I think we are getting there, and I think our understanding of the basic biology has really improved over the last 2 decades, and hopefully now we can translate that into treatment. So I'm just going to end there. I'm going to say thank you to a wonderful lab that I work with in Oxford, fantastic collaborators both in Oxford, but also really across the UK and the world. And thank you to my funders, and thanks for the invitation.
Thank you so much for that fascinating and very logical presentation. Matt would have loved it. William would have loved it, and he'd have taken pictures. And I tell you who else would have loved it. Pat would have loved that. Pat would have loved that, wouldn't he? And see where we've come to today. Any questions? Can any of the mutations that you've described or discovered so far actually happen in vivo as a result of any insult to the nervous system?
So, I mean, I think most of these mutations, they're happening at germline rather than somatic mutations.
Right.
And I think it's just a case of bad luck genetically rather than kind of an environmental insult impacting on these mutations. But it's a good question.
Thank you.
But this is saline treatment to describe, for the SMA1 condition. Do you need to do this early on when they are born, or can you do
Yeah, so I think that's a really interesting question. And the answer is I don't think we will know till we do the clinical trial. I think one thing that is good is that, so Mary Riley's leading on that clinical trial, and it's going to be long term. So it's not going to be kind of a 12-week trial. It's 6 months to a year. And also she has, with these kind of trials, it's very important we have a responsive outcome measure. So we will be measuring symptoms such as pain, but also she has found that MRI of muscle gives you a very good index of denervation that it actually tracks disease. So she knows that she can see over a year progressive, as it were, denervation of the muscle. And so the good news is that what we're trying to do is that we're halt it, and we think we'll be able to see that signal. Because I agree, ultimately, you in the ideal situation, you would be diagnosing this condition and then starting these people on serine straight away. And maybe ultimately we will be able to get to that. And neuromuscular disorders are kind of moving in that direction. So you may or may not have heard of gene therapy for spinal muscular atrophy, but it's kind of interesting that people are now thinking around the ethics that what's been happening so far is that we've been taking children that are recently diagnosed with spinal muscular atrophy and trying to treat them as quickly as possible. Now, actually, there's trials of neonatal screening programs for spinal muscular atrophy because we know we have a treatment that really has an impact, and the earlier you give it, the better. So I think ultimately we would want to move in that direction. But right now, we do think we have a trial design that's going to be responsive enough that we can see a signal.
That's good. And it was great to hear you, that wonderful paper with Solomon. Solomon started here in Liverpool.
Yes.
He was a diabetic specialist. At the days when diabetic specialists didn't know that people with diabetes had pain. David Boucher was one of the first people that explained that to people treating diabetics. And they said, oh gosh, I didn't know they had pain, and Solomon was one of the first started.
Yeah, no, as I said, it was an amazing trial that he led there.
This is very complex, isn't it? You've got all these first-line drugs, and then you've got second-line drugs. Do you ever think that AI would be better at managing these than doctors in the future?
Yeah, I mean, I think that's an interesting, so at the moment, no, but, and I think the thing about AI is, you need something to train it on. So it may be ultimately that if you had good enough data, and in a way, what I was saying about the machine learning and trying to look at the predictive factors for neuropathic pain is kind of using that principle. You're training it on a very complex, large data set, and it's recognizing patterns that potentially a single human might not see. So I'm not against the idea. I don't think we're anywhere near that yet. But I think you will find, those computational techniques will be used more and more within healthcare. One of the dangers, though, that I think isn't always appreciated is that you're kind of as good as your training data set. And so you might train an AI data set here, and then, I don't know, maybe in East London, for instance, it may not perform as well. So you need that care, and it's also as good as the data that you put into it. One of the things we've found with kind of when we're looking at big population cohorts, if you look at kind of just general medical notes, trying to work out whether someone has pain, how severe that pain is, whether it's neuropathic pain or some other form of pain, is incredibly difficult. So it's not going to be simple to do that training.
Yeah, sure. Well,
David, somebody's actually asked
yeah.
online if you can go in the chat.
Oh,
yeah.
Right.
Let me have a look.
There you go. Put on this one for you.
Yeah, that's a really interesting question, actually. So the question is, I'll read it out for the audience. Have you any comments on how to differentiate neuropathic from I think you mean nociplastic pain in a non-QST clinical setting, given that most fibromyalgia patients score highly on the likes of Pain Detect and Lance? So we were discussing fibromyalgia earlier, and I think it's a kind of very topical question, partly because there is some argument that there may be a neuropathic component to fibromyalgia. And the reason I'm saying that is actually my personal feeling is that fibromyalgia is a very, very broad church. And it's not, you know, basically these days, if you have chronic widespread pain, you pretty much can be diagnosed with fibromyalgia. And I suspect there may be lots of disorders within that. The reason it's kind of risen to topicality has been a number of papers now showing that if you do a skin biopsy in people with fibromyalgia, that the intraepidermal nerve fiber density is reduced. Shouldn't overinterpret that, because there's a difference between being somewhat reduced and actually being at the level we would diagnose, for instance, a small fiber neuropathy. And also some microneuropathy studies, which Geordie Sarah has shown abnormalities in the kind of action potential generation within nociceptors in the context of fibromyalgia. So I'm open to the idea that there may be a group of patients with fibromyalgia where actually there is some primary afferent injury contributing to the condition. Do I think the central nervous system is incredibly important? Yes, I do, in fibromyalgia. So I think sometimes I go to meetings and there seems to be this kind of, I almost think it's a false dichotomy of, is fibromyalgia all peripheral neuropathic pain disorder, or is fibromyalgia all the central nervous system? I will go back to kind of the theme of this whole lecture, which is there's multiple factors operating in very complex ways, probably interacting, and I think it's too simplistic to say fibromyalgia is either all in the periphery and all in the CNS. This question of, is there a I think the simple answer to that is no. I think you're right. I think if you were to do a DN4 questionnaire, it's interesting. Patients with fibromyalgia quite often complain of pins and needles or electric shock sensations. I think I completely agree that they score quite highly on that. I do actually think that in a way, the best grading of neuropathic pain, coming back to the beginning of my lecture, is that neuropathic pain special interest group kind of grading system. And what you won't find is fibromyalgia is sensory deficits on clinical examination in a neuroanatomically plausible manner. So what I'm saying is you won't find loss of pinprick or loss of thermal sensation. So I think ultimately that probably is the best arbiter of that. Sorry, that's a long answer, but it's a very difficult question.
No, well, thank you. It's my job now to thank you on behalf of the Pain Research Institute. Pain Research Institute has been going for 46 years now. It's incredible, isn't it? Set up by Sam Lipton. And of course, the old guys who worked on it had a fascination with neuropathic pain. People like David Bausch and John Miles, as well as Sam. It's going very well, the Pain Research Institute, and we're delighted. I don't know if you knew, but Andreas Goebbels has just got a personal chair in pain at the university, so that's fantastic news. And one of our patrons, Liz Muirhead, has just been made Freeman of the City of Liverpool, which is brilliant. And that's fascinating. Lorna and I were on a ward in 1977 doing epidurals. That's how old I am. So it's fascinating when she now becomes such a famous person. But you've given a really great lecture tonight, and we've thoroughly enjoyed it. And we have a little presentation.
Oh, thank you. That's very kind. Thank you.
And we want to thank you all very much.
Thank you.
Everyone's enjoyed it online. I'm sure everyone's enjoyed it. Thank you very much, and enjoy the rest of your evening.
Thank you. Thanks everyone online.